on the participant list, so I just want to make sure we know who's here from the membership. So do we have JJ Burnaby here?
Yes, sir.
All right, thank you. Dr. Berry, we know you're here. Dr. Vaglienti.
Here.
Thank you, sir. Dr. Milton.
Present.
Thank you, sir. Dr. Malil. Rudy Malil, are you on the call? All right. Mike Goff, are you on the call? Mike Goff from Board of Pharmacy. Okay. Dr. Antolini. Dr. Antolini, are you on the call? All right. And I think I saw Dr. SQ on the participant list. Sir, are you here?
Yes.
All right. Thank you. I'm glad you can make it. All right, Dr. Berry, very happy we can have this meeting tonight. I know it's been a struggle to get this particular work group scheduled in the past. I'm hoping that's going to change in the future with our new membership that was recently appointed to the board. I want to give a very quick update on office activities, and then I'll hand the meeting over to you. As many of you may know from the news, retail sales have started for medical cannabis in West Virginia over the past few weeks. At this point, we have dispensaries open in Morgantown and Crystal, help me out. I have a brain block. Where's the second one?
Weston.
Thank you. That was embarrassing. Morgantown and Weston. Recently, over the past week, we've also certified dispensaries as operational in Huntington and Parkersburg. However, there is a quick note with those dispensaries. They are standalone dispensaries, meaning they're not vertically integrated. Those companies don't also hold a grower or processor license. So there's not necessarily product available for those dispensaries at the moment. They have to make those agreements with licensed growers and processors to obtain products for their facilities. So we don't have a solid date on when those facilities will begin retail sales. We expect to certify several more dispensaries as operational over the next couple of weeks. So we should have a significant number operational by the end of the year, and that will continue into early 2022. Also with additional growers and processors beginning to harvest their product. So retail sales should greatly expand in early 2022. However, they are limited at the moment. So Dr. Berry, that's all I have. I'll turn the meeting over to you. I would recommend that you set ground rules for public participation, because we do have a significant number of folks with access to the meeting tonight. Typically, we've given 90 seconds at the end of the meeting for public comment, but I'll leave that up to you.
Very good. Thank you, Jason. I believe last time I took it to a motion regarding the public comments. And so if we can get a consensus among the subcommittee members to have 90 seconds as the limit when we're done with the regular meeting for discussion from other participants. So is that in accord with the rest of the members?
I would support that.
Yes.
Yes.
I would also support that.
Okay, anyone object to that? All right, thank you. Jason, will you or somebody from the board be monitoring the time when it comes to that?
Yes, sir, we will. And we'll ask one more thing from our public participants that have been given access. Please do not use the chat for communication during the meeting. That's not the purpose of that feature. We do use it to facilitate public comment at the end of the meeting, and it makes it more difficult when people are utilizing that function for other purposes. So please do not do that.
All right, thank you. So just let me briefly review what we did. Well, actually, I suppose we should approve the minutes. Did the minutes go out to all of the board members, Jason, from last time?
Yes, sir, they did.
And actually, as I look here right now, I don't believe we have Dr. Antolini on, so we can't approve the minutes because no one else was here. So let me just go ahead then and review what we discussed. Basically, we had Mike Goff, who's the head of the West Virginia Board of Pharmacy, to discuss some of the nuts and bolts of what it would mean to put the cannabis product on the reported CSAP, or the Prescription Drug Monitoring database, and CSAP is the vendor for West Virginia. And so we went through that, had a number of discussions regarding it, and noted that it is possible. And it's what I was hoping to do today is get a consensus among the subcommittee members of whether or not we did want to go forth with putting that as a recommendation to the board. So that is going to be our task today, is to determine indeed we'll take a vote if we do want to make that a formal recommendation to the board. One of the issues that I keep going back and forth with is what we discussed last time. Is one way to do it is to just have a binary indicator that the physician can pull up a report on the CSAP controlled monitoring database that says whether or not product was dispensed, for a given period of time. And so definitely that would be the least labor intensive way to do it. And it would just give us information as physicians to whether or not our patients have been dispensed cannabis through the dispensaries. So that's one way to do it. But then another way is what Ohio does, and JJ Barnaby could speak more of this. And I've seen some of the reports since then. And what they do is they actually list the product that has been dispensed and then the amount as well. And that gives a good amount of information that I do think would be helpful for a physician to know. And the reports I saw, I mean, you could tell whether or not somebody is taking, just a little bit or, really taking a lot. And then you can have a good conversation with the patient regarding what that means. And so I just wanted to throw that out as discussion for what others in the subcommittee thought about that. Did you think it would be enough to just have a binary report if we were going to go this route, or do you think it would be helpful to actually have the listed product that was dispensed, and just hoping to get a consensus in that? So I will put that on the floor for discussion.
Dr. Berry, I apologize for interrupting, but do you think it would be helpful just to give an overview of how this process works for the 2 new physician members?
Help me, Jason. What are you thinking?
So just explaining that this is a work group. We're talking about a recommendation here to the legislature, and the fact that MCAB can't change the law themselves. It's only a recommendation for a legislative change to the members of the legislature.
Yes. So thank you. Thank you for that clarification. So that is our role, is making a recommendation. We do not have, any scope or power to make changes. It just really comes down to, and the way I see this committee primarily as healthcare providers, to say this is a group of healthcare providers who believe that this would be a helpful direction, and in whatever we decide, with any particular issue in this subcommittee, but particularly then today, that this would be a helpful thing, and put forth the recommendation to the board.
Hey, Dr. Barry, I wanted to let you, I just want to make sure we're on the same page when you talk about binary I'm
Yeah.
not sure, I'm not sure I'm following you exactly, but what I can
Okay.
tell you is I had filled a benzodiazepines for 2 different patients today that came to my West Virginia store. Now, we're in the Northern Panhandle, and whenever I do a controlled substance lookup, when I go to fill that prescription, that's certainly our policy. It brings up the dispensary items that the patient received in Ohio. And what we do as a matter of policy is notify both physicians that there is, what they're taking. And I can tell you that this week I've had 2 patients with benzodiazepines. One doctor refused to prescribe it any longer. He was unaware of the patient's participation with the dispensary. The other doctor was fine with it, knew, acknowledged it, and was on board. So I think that's just a very simple example on why that's important. I mean, you're the doctor. You're the one who's going to be in charge of somebody's care when it comes to prescribing medicine. You've got to know whether they're a dispensary participant or not. And that controlled substance monitoring program is the only way to know that, I think, as a pharmacist. So I just wanted to throw that out there.
Yes, that's very helpful. And let me then clarify what I mean by the binary issue then. Is it important enough that the physician would know the actual amount of and the products that were dispensed, or is it enough that the physician knows that a product was dispensed? And that's what I mean by, that's what we discussed last time.
Yeah, I would say from the pharmacy, from my conversations that I would have with patients, and it might be a little bit of a cop out, but as long as I know that they're participating with the dispensary, that's what that would help me enough to have a conversation with them. As far as the exact limits and what they're, that would be nice, but I'm not sure that it would make a difference in my conversation with the patient.
Thank you. Dr. Milton, you were going to say something?
Well, to me, the model has been established when we're thinking about controlled substance monitoring programs. You look it up, you see that there's a prescriber, you see that there's an amount, and you see that there is a recommended number of a time limit. I think with that model has been successful, and I think it should be highly considered.
Okay. And would you then say it would be preferable to actually know the amounts and the time limits as opposed to just know it's dispensed?
I think with the various forms that are available, the concentrations of various cannabinoids, I'd say yes.
Okay. Any other board members would disagree with that?
Dr. Barry, I want to point out something from an operational perspective. Just be aware that unless a physician specifically limits a patient to a certain form, there's nothing preventing a patient from switching the form and amount of medical cannabis that they purchase every single time they go to the dispensary. So that could change very frequently.
Got it.
That's a good point.
Thank you. So practically then, if I had a patient, Jason, on Tuesday of this week, and I ran a report, then it could say something much different if I ran a report next Tuesday.
Yes, sir. And that would be the case for almost all patients. Physician limitations for form or duration of medical cannabis are extremely rare. I've given some examples in the past. Say if a patient has COPD, the physician may limit them from inhaled forms of medical cannabis. But again, those are very, very rare on the certifications that we've seen. So 99% of patients could switch forms and amounts every visit they make to a dispensary.
Thank you.
Who would be responsible for reporting to the pharmacy database? The dispensaries?
Yes.
Is there any way we could contact someone at the ORs and see how they do it so we don't reinvent the wheel?
Can you speak more about that, Dr. Vagliente, and what you're thinking?
Just that Ohio has a very nice system, and I'm sure they went through these same discussions. And so if we decide to move forward, maybe we could contact them or other states who have done this so that we can model after them rather than trying to plow through from the very beginning.
Folks, I just want to, again, from an operational standpoint, point something out. We don't necessarily, and I'm not trying to prevent you from doing this, but we don't necessarily need to hash out details at this stage. That can be done by rule later on in this process if the legislature opted to make this change to code. Typically, details like this aren't written out or spelled out in code. It's done by rule, which explains how to operationalize the code. So not trying to deter you from discussing details, but they're not really necessary for you to make a recommendation.
Thank you. That clarification is helpful. In my estimation, I do think it would be helpful to the board to at least settle the decision, or at least what we think would be the best recommendation as far as one, do we want to have the dispense product on the controlled database monitoring CSAP, and also as much information as we can, something like Ohio, as opposed to just yes or no. Any other discussion for or against? Hearing or seeing none, are we ready to put this to a vote? Okay, so I will take a stab at this then and say our recommendation would be that we do recommend that dispensed cannabis products are listed on the CSAP database, and that we would recommend as much information as possible for medical decision making, something similar to what Ohio does.
Second.
Okay, so I moved it and it's been seconded, and now I will leave it to a vote. So all in favor, say aye.
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 Any against, say no. I think we got everyone captured. That's that. All right. So that passes as a formal recommendation from our subcommittee that we will pass along to the board next week.
All right. Thank you, sir. We will write that up in written form in order to facilitate the vote next week for the full MCAB board. Is there anything else you want to discuss during this subcommittee meeting before we move to public comment?
That was the only agenda item that I had and that I understood we were tasked with today.
Okay. All right. With your permission, we'll move to public comment. Just like last week, I would ask that the public place their name in the chat box, and we'll go down one by one and let folks comment for 90 seconds. So again, if you wish to comment, type your name in the chat box. Okay, Let's start with Dr. Michael McKenzie.
All right. Hello, good evening, everyone. Glad to be here. Especially welcome for the opportunity to at least share, what we do in Florida. So, maybe you can, see what we do. And if you want to incorporate certain things into your program, you can do so. Now, as far as the tracking of the milligrams of product, we have that in our Florida medical cannabis sort of tracking program on the website for the Office of Medical Marijuana Use. And, it is broken down by delivery method. So you have vaporization or inhalation, sublingual, oral, suppository, and different forms. And then you could put the daily maximum dose of milligrams per day of that particular product. Usually we put a larger amount so to allow patients to get a variety of products, because certain products the patient may not take well to. And it's not as if you can just go and turn it in and get a refund. This allows the patients to try different products, and if something's not working, they can switch to something else. Now, as far as the narcotics, the controlled substance database, it is not linked per se to the OMMU database, but the patients that enroll in this program, they're actually trying to get off narcotics. They're trying to use less benzos, less opiates. So even though they may some be on some narcotics at the same time, a majority of them are trying to get off of them.
Dr. McKenzie, your time has elapsed. Thank you.
He's up.
Dr. Stout.
Hi, thank you for allowing me to speak. I am an addiction psychiatrist from Colorado, and I just really support this effort to get it on a PDNP-like program because we have not had that in Colorado, and it has been really detrimental to patient care because, for example, I'll see a patient, and I was frequently seeing patients who were referred to me because their medicine wasn't working. So they were still very anxious, they were depressed. And then I was finding that they were using high potency THC products that I didn't know about. And then I'd ask if I could speak to the physician who was recommending the product. They couldn't even remember who the person was because they only had to see him once a year. They only saw him for 5 minutes. I mean, the system in Colorado has been very poorly run, in my opinion. And I'm hoping that you have a much better system because cannabis products interact with psychiatric meds a lot. And so if somebody is not doing well, it's really helpful to know if they're taking other products like things from the dispensary so that we can discuss it. And then it would be very nice to be able to discuss it with the physician who's recommending it. So that is, to me, what's best for patient care. So I really support you trying to do this, and I think it's a great recommendation. Thank you.
Thank you. Next, we have Teresa King.
Thank you, Jason. We operate a dispensary in Ohio. So if anybody would like to see how ORS works firsthand and how it goes from the dispensary to ORS and what we see, more than happy to share that, do a Zoom call or whatever, just so you guys can get a firsthand look at that. I'll put my email in here, and if you want to, you can reach out.
Thank you.
Thank you.
Mhm.
Next, we have Erin Carey.
Hello, excuse my presentation. I just got done exercising. First, I want to say, I think it's an excellent idea. I've supported this from the spring whenever it was approached. One of my concerns is whenever the gentleman said in the beginning that a physician found out that a patient was on cannabis and they dropped their prescription of a benzo, that's concerning to me that physicians will have the ability to do that. am involved in a lot of nursing organizations, became a co-owner of a dispensary. We sold it here in West Virginia. And I like the model that that Maryland has, and it has nurses as clinical directors, you know, and all the academic certifications that I've been working on, it's very approached in a coaching sort of way. So I only have 90 seconds here, so I want to keep on moving through this. I agree, high potency cannabis, it interacts with psych meds, but so do certain terpene profiles. So if we're really gonna, you know, approach this even further, perhaps maybe even terpene profiles should be placed on there. You know, and yeah, physicians and the amount of recommending physicians that we have, are they going to be able to adequately monitor their patients? As the last physician just mentioned, there are risks involved with that. Now, I know having physicians as clinical directors could be quite pricey, but it might be a consideration to follow some of Maryland's model, that they have nurses and they're actually working on restructuring some of that, and they've been doing it. Those are my comments. So, yeah.
Thank you, Ms. Carey. Next, we have Howard Swint.
Yes. Hi, everyone. I was talking to a doctor at a Christmas party Sunday, and I was explaining the endocannabinoid system to him. Now he's retired. He had no idea what I was talking about. And I'm doing some research on neurotransmitters, neuroplasticity, et cetera, et cetera, et cetera. No, I'm not a doctor. No, I'm not a medical professional. I'm just doing it out of just pure interest and writing it, hopefully for a book. But the reason why I'm calling in, another doctor today suggested that I might want to come and at least offer to you, the working group and maybe the full board, maybe a very brief presentation on what I've learned and how it relates to the potential upside for the different products that are in the marketplace, how they would be superior to the Delta 8 products, given the contamination issues associated with those. And happy to do that by phone, happy to do that in person if you would have any interest in it. It's been fascinating for me to learn a great deal about what you may already know, but there's just a growing body of information out there that I thought I'd at least offer to share with the working group and then the full board if you'd be interested.
Thank you. Anyone else for a public comment? If you wish to comment, please type your name into the chat box. All right. All right, Dr. Barry, that looks like that's it.
No, I think you're missing some folks. It looks like Barry Gordon has a comment. You're on mute there, Jason.
Sorry, I didn't scroll my chat down.
Yep, looks like a few people still have comments.
Yeah. Let's see, Barry Gordon, Dr. Barry Gordon.
Yeah, thank you very much, everybody. Listen, I'm an Ohio emergency medicine physician, retired and moved to Florida, 35 years up in Ohio, knowing what I know. Yes, the OR system is excellent and a system to emulate. Listen, I've done medical cannabis for 5 years. I sit on the state's medical marijuana advisory committee. I do it with honor and integrity every day. Don't fear medical cannabis if the doctors take it seriously and educate their patients when they come into the clinic. We take pride in our clinic of making sure that every single patient knows of the endocannabinoid system, what THC is versus CBD and all of the other cannabinoids. We also make sure that they know of the different delivery methods of the cannabinoids, be it inhaled, tincture, topical. And we believe that that's a very safe way of our patients and everybody have no fear of medical cannabis. If done right, it results in a reduction of your pharma burden, right? It's a fascinating thing to watch. And every conventional medical practitioner needs to understand right now that patients have been using cannabis for years. They'll continue to use it. And the exciting thing now is that we can offer a much better regulated, pure product. So I invite anybody to reach out to me. I'm very easy to find. It's venice.care.com in Florida. I have over 5,000 patients. I also say that welcome to Trulieve in West Virginia. I think you'll find them to be a very excellent educational partner as you begin to educate your doctors and your patients. So welcome, West Virginia, and all the luck to you Once again, happy to help out whenever I can. Thank you very much for allowing me to speak.
Thank you, sir. Dr. Husted.
Hi, yes, thanks. I'm very much in support of having it as part of CSAP. I think just as much as patients should be able to make an informed decision to their healthcare, physicians should also be permitted to make informed decisions in terms of prescribing. The idea that a physician shouldn't be allowed to know what their patients are on is kind of preposterous to think about. I think the more we know, the better informed we can be as physicians. Again, we can always learn more, but the idea that we should like hide it from them and you shouldn't disclose to them what their patients are taking, something that could potentially dangerously interact with the medicine they're already on, again, is kind of preposterous to say that that would be a bad thing for a physician to have more knowledge. So I'm very much in support of CSAP. I think the more that a physician can learn from it, the better, especially if you have a patient that is on multiple addictive medicines, which cannabis is addictive and certainly causes addiction. And we need to keep an eye out for that in patients that have opioid overdoses, et cetera. For some, it may reduce polypharmacy, but it can also increase addiction and addiction-related behaviors. So let's not forget that. Thank you.
Thank you, sir. Let's see. Next up, Joseph Vernice.
Yes, hi. I have a question as well as a comment. My question is, what is the primary purpose of a database? And my concern is exactly what one of the previous doctors mentioned. Not all doctors understand the endocannabinoid system. And if we're going to have a database, there has to be training of physicians. I see if I go to a pain management doctor, they don't know anything about medical cannabis. And when I tell them that I would like to start taking it, they're all against it and everything, and they have no knowledge about the benefits. So my concern is that you put this onto a CSAP database and you have a doctor that's going to either take away your supplementary meds because they don't understand your pain management and how cannabis can be integrated into that. I think that's probably my time. So if somebody can comment on that, I'd really appreciate that.
Dr. Berry, this is public comment. I'll leave it up to you whether or not you want to address the question.
I think, suffice to say kind of what some comments have been already. It's the physician. If we are determining, and we have in West Virginia, that this is a medical product, then it is a physician who should be the one who follows this from a medical standpoint. And they should be armed with all the information necessary so they know what their patients are taking and the potential risks and potential combinations of other medications, et cetera. But I certainly also agree with the sentiment that physicians need to be as educated as possible regarding cannabis, the endocannabinoid system, and the potential benefits and the potential harms.
Okay, finally for public comment, we have Kevin Waugh.
All right, good evening. I just had a quick question. From an industry standpoint, with the dispensaries, we're already putting this, patients in the database for OMC, if I'm correct. And now you're asking us to put it into a separate database. So we're going to put the same information into two databases. I don't understand. And is everybody in the dispensaries going to have access to this CSAP database? And why can't they just, get the information from OMC since we're already programming it into the database there?
So Dr. Berry, if you don't mind, I can take a stab at this real quick.
Please.
Yeah, so Mr. Waugh, again, the board's setting a direction for recommendation here. my feeling of what you're asking is more on the operational side. And we're not at the point of having an operational plan at this point. Most likely, the metric seed to cell system could be linked to the CSAP database. But again, those are operational plans that would have to be explored if the legislature were to pass this requirement. And we're not anywhere near that point yet. So not downplaying your comments, but it's something that will be decided later and operationalized later. Dr. Berry, if you want to add anything to that, feel free.
Nope.
Okay. All right. That looks like that's the end of the public comments. Dr. Berry, if you would, if you don't care, I'd like to get some feedback from the members just to try to solve some of the scheduling issues moving forwards. Again, very happy we can make this meeting happen. It's been tough in the past. Do the board members, or the work group members, I should say, have any feedback on, meeting times, meeting days that might work moving forwards, or just any other scheduling recommendations that would make this easier for your attendance moving forwards?
Well, I could just tell you that you given all those options, I mean, that helped me be able to make sure that I'm here. So as long as there's more than one option and there's ample time for us to plan, I think we're in good shape. Keep them away from Saturday night. That's all.
Okay. In particular, the new members, any comments from Dr. Vaglianti or Dr. SQ about scheduling moving forwards?
Not new
No.
basketball.
Did I hear avoid basketball?
I think that's what Dr. Baglianti said. He's probably
Oh.
checking the basketball schedule.
Okay.
I frequently have other Zoom meetings scheduled on Wednesday evenings, maybe another day of the week, or we could alternate the days of the week. But
Okay. We'll try to give, further notice moving forwards also. We were a little bit rushed with the new appointments to try to get this scheduled this time around. But definitely we should have some more time for future meetings. Okay, Dr. Berry, that's all I have.
I will entertain a motion then to end the meeting.
So moved.
Second.
All right, all in favor, say aye.
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 Right. Thus, we have concluded our meeting. Thank you, everyone, especially for the members who were able to attend and make this happen. And thanks for the public comments as well.
Thank you.